In 2025, 29% of solo practitioners and 13% of small practices received the maximum 9% MIPS penalty for 2023 unexpectedly. If your practice was one of them and you're trying to make sure that it never happens again, give me less than 10 minutes and I'll share with you the 3 key steps you should take to avoid unexpected payment adjustments and how to identify where your breakdown is actually occurring while you can still do something about it. Because what you do in 2026 determines your 2028 recoupment. Now think about what you did, how you submitted, how you performed, how you collected in 2024 and 2025. And if you're still guessing this year about why a metric failed, you will repeat that same recoupment cycle year after year. So that means you nor anyone on your team can afford to be guessing about anything, including the reason why a specific metric is failing in your practice specifically. So if you need help with this, I have an actual video using the exact clinical improvement map where I show family practices how to connect metrics, billing, patient pathway, and documentation using a hypertension example, and to simplify the metric using a hypertension example. If you're new here, hello, I'm Talitha, a former RN with 20 years of clinical care experience, now working with small, independent, and rural primary family care practices to prevent negative payment adjustments before they happen. Because if you see Medicare, managed Medicare, and Medicaid patients, you're getting hit with MIPS and HEDIS penalties. So step 1 should be to simplify. Simplifying is not only to decrease confusion with staff because repetition creates memory, but once you've done something the same way for so long, it's easier to spot outliers. And that's what you need for your staff to start being able to help you spot gaps and leaks that your patients fall into. That's how you become proactive and value-based care ready. So then once you've simplified it, now you want to ask, why is this metric failing? And that's where the clinical improvement map comes in. So in step number 2, you want to actually map the breakdown. We want to know who, what, when, where, why, and how much the practice is performing when it comes to that metric. If you don't understand why a metric is failing, you'll implement random fixes, and random fixes do not protect the revenue. You don't know if it's a documentation gap, a follow-up gap, attribution issue, denominator inflation, a coding issue, patient complexity, workflow timing. You don't know what it is. If you guess wrong, you waste 6 months. And 6 months from now, the year is almost over. And we are essentially trying to prevent penalties. So you want to look at 6 main areas. The metric itself. What penalties or incentives does this risk tie to? Then you want to look at billing. How will this affect revenue? Do we already have denials? Are we using the G codes to show complexity? Then we want to look at the patient pathway. Where along the patient journey does the problem show up and who owns that point? Where are additional touch points that offer opportunity for intervention? Patient follow-up. Are they taking their medications? Are they exercising? Did they change their diet? Are they doing the things that they need to be doing? Specialty referral coordination. What hands-off or transitions create inconsistencies? When we refer our patients, are they getting good quality over there? Because it matters now. Their quality affects our quality. Then we look at documentation. Are our complex patients coding true complexity? Are we using the right codes we should be using to match this metric? Are we getting everything in within the timely restraints that it's supposed to be? Then for each one, we want to know what the requirements and the barriers our practice has to meeting each goal. Then for step 3, you want to measure internally before the penalty. How are you tracking it now? Do you track hypertension rates? If you're not measuring numerator and denominator in real time, you are waiting for feedback reports to tell you what already happened. That also means a higher chance of penalty because whatever it says is too late to fix it. And waiting till it's too late to do anything is going to keep you getting blindsided year after year with penalties. So then we want to look at what action needs to increase or decrease for success. I use a clinical improvement map to see exactly where the system breaks before we touch the workflow. And you want to do this as a team. Everybody needs input. Everybody who is involved in the patient journey needs input. So if you want to do this in your practice, make sure you comment down below to let me know that you want this guide. You can comment map, and I'll send it to you. There's a video, like I said, that walks you through step by step. Until the next time, I'll see you in the next video.